Assalamualaikum everyone. I'm recording my lecture after quite a long gap as it was a busy week. But coming today with a very important topic, that is management of ovarian cyst in premenopausal women. So in my previous lecture, we have already discussed the history taking, important investigations, and what to examine, how to examine, and this is just for the benign cyst. For the malignant cyst and in the postmenopausal woman, we will be discussing in our another lecture. So this is the management of ovarian cyst in premenopausal women. So we will be starting with this very important lecture. Okay, so first of all, discussing the management protocol. So whatever kind of ovarian cyst we would be dealing with, this management protocol has to be followed, which involves conservative management wherever possible, use of laparoscopy instead of laparotomy. Laparoscopy is preferred because of less scarring, less morbidity, quicker recovery. It is costly, it requires expertise, but it is preferable because of these reasons. Timely referral to gynecological oncologist, very important. If the cyst appears complex, or if the symptoms are going towards the symptoms are showing kind of malignant changes, so you have to refer the patient timely to gynecological oncologist for further management. Okay, so now coming towards asymptomatic woman with simple ovarian cyst. If the cyst is less than 5 cm in diameter, these cysts do not require follow-up. They resolve within 3 menstrual cycles. Means after 3 months, mostly these kind of cysts they resolve. If the cyst is in between 5 to 7 cm in diameter, these cysts requires yearly ultrasound follow-up. C125 only if cyst is persistent. Okay, and if the cyst is more than 7 cm, then you have to go for MRI or surgical intervention, because there is most likely chances of torsion, rupture, hemorrhage in these cysts. Persistent asymptomatic ovarian cyst. Suppose if after an air repeat of ultrasound scan, still the cyst is present, whether it is 6 cm, 7 or 5 cm, then you have to go for surgical management. Okay, so there are certain important points. Premenopausal simple cyst with no feature of malignancy and the diameter is less than 7 cm, then there is malignancy risk of less than 1%. If premenopausal and postmenopausal cysts are greater than 7 cm, then there are 7% risk of borderline or malignant ovarian tumors. So for less than 7 cm, risk is less than 1%, but more than 7 cm, the risk increases to 7%. And this is for both premenopausal and postmenopausal females. In between 5 to 7 cm, 50% of cysts detected in premenopausal women are functional. 90% of these resolve within 2 months. So this is very important while managing patients with ovarian cysts, and this is a very common problem. Most of the times women come with ultrasound scan showing ovarian cyst of around 4 cm, 3 cm, and they get very worried for its management. So this is the way. Okay, now when to do surgical intervention in premenopausal women. So there are 3 reasons to perform surgery in these women. First one is if the cyst is complex. Now complex ovarian cyst, they could be hemorrhagic or corpus luteal as well. So you have to exclude these 2 conditions, and after that you can go for surgical management. If the cyst is symptomatic, like it has kind of pressure symptoms, pain, or few cysts present with menstrual irregularity, heavy bleeding, urinary frequency, so there are multiple things. So if the patient presents with symptoms and suspicion of malignancy, so these are the 3 reasons for which surgical intervention can be performed in these women. Now coming towards management, very common practice we have observed in our everyday practices, that the prescription of combined OCPs. OCPs are prescribed very routinely in our practice for the resolution of ovarian cysts, but they have definitely they do not have any kind of role in the resolution of functional ovarian cysts, so they should not be prescribed. Laparoscopic route is preferred for ovarian cyst up to 7 cm, because if the cyst is more than 7 cm, so most of the times while performing laparoscopy, the cyst can get ruptured during removing it, its contents can be spilled into the abdominal cavity as well as it is difficult as well. So for the cyst larger than 7 centimeter, laparotomy is preferred. Why? Because you can also look for other pathologies very easily, and performing surgery in a patient with larger adnexal masses or cyst is easier if laparotomy is performed. Okay, so if during laparoscopy the cyst is aspired, then the recurrence risk is 53 to 84%. So this is very important while doing cyst aspiration during laparoscopy. This is the recurrence risk. Consideration should be given to avoid spillage of contents, as malignancy could not be 100% excluded. Use of tissue bag. So a tissue bag has to be used, and it is to be placed inside the peritoneal cavity to avoid the spillage of cystic contents. Chemical peritonitis is less than 0.2% of the cases. If spillage occurs, consider extensive peritoneal lavage. It could be with normal saline, with ringers. So with warm fluids, the lavage should be occurred if in case spillage has occurred. So while removing the cyst, it has to be taken care to remove the cyst capsule carefully, so that there is no chance of any kind of a spillage and leaking of the cyst contents. Okay, now possibility of removing an ovary should be considered. So the patient and her attendant should be counseled preoperatively that it is possible that if there is very less ovarian tissue is left behind, so there is a possibility that ovarian tissue might be removed during surgery. Removal of benign ovarian masses should be through an umbilical port. So why? Because it has quicker recovery, less postoperative pain, improved cosmesis, fewer incisional hernias, rather than if a cyst is being removed by lateral ports, so it results in most of these complications. So yes, umbilical port is preferred. So there are certain special situations. What are these special situations? If there are suspected endometriomas, so what has to be done? They appear complex on ultrasound scan. Their appearance is like ground glass appearance, and their CA125 is also raised, less than 200 but raised. So MRI can be useful for confirmed diagnosis for suspected endometriomas. In endometriomas, the malignant transformation occurs in less than 1%. If the cyst is more than 9 centimeter in diameter, and if the woman is over 45 years of age. Now coming towards pregnancy, very common presentation of adnexal masses with pregnancy. So the incidence in pregnancy is 30% in first trimester, but most of these are corpus luteal cysts, which are 90%. And these cysts resolve spontaneously, so no intervention is needed for corpus luteal cysts. The complications with ovarian cyst in pregnancy, it could be torsion, rupture, hemorrhage, and malignant transformation is less than 1%. Now, when to perform surgery in pregnancy? There are certain indications. If complex cyst is with suspicion of malignancy, if the cyst is kept on increasing in size, symptoms which are suggestive of torsion, rupture, or bleeding. So for these three conditions, it is advised to perform surgery in pregnancy. MRI is useful for diagnosis. Laparoscopic approach is recommended in pregnancy as well, and second trimester is the safest to consider for surgery. It is easy to perform surgery in second trimester. Most of times the pregnancy, mostly they result in miscarriage in first trimester due to fetal anomalies or any kind of fetal abnormality, or if there would be corpus luteal cyst in first trimester. So all of these things they get aside in second trimester, so the surgeries can be performed very easily and safely. If cyst diagnosed at time of cesarean section, it should be removed, and it could be cystectomy or oophorectomy rather than aspiration. Indications for conservative management. Conservative management in pregnancy for ovarian cyst, it should be done if the cyst is asymptomatic, it is simple, less than 10 centimeter, and if the cyst has not increased in size at detailed 20-week anomaly scan. If the scan is being performed at 20 weeks and if the cyst has not increased in size, then there is an indication for conservative management. It is necessary until after delivery. No further scan is necessary in this case. Follow up ultrasound scan 6 weeks postpartum to evaluate for the cyst again. Okay, so this is an algorithm for the management of premenopausal ovarian cysts. So ovarian cyst ultrasound appearance. We will be starting with the simple cyst. Simple cyst less than 5 centimeters, so no CA125 is required, and the patient can be discharged easily.
If the cyst is simple but the diameter is more than 5 centimeter with normal C125, and it includes simple single thin septum. So for this, if the diameter is greater than or equal to 7 centimeter, or if diameter is less than 7 centimeter. For less than 7 centimeter, there is an advice of doing conservative management. The conservative management, it includes ultrasound scan and CA125 yearly, and if the cyst is resolved, then the patient can be discharged. If on repeat scan the cyst is increasing in size or complexity, then surgery is advised, and the surgery would be laparoscopic surgery. If the cyst remains unchanged, then it depends on the patient preference, that whether she wants to go for ultrasound scan annually or whether she wants to go for laparoscopic surgery. If on an annual ultrasound scan the cyst is resolved, then the patient can be discharged. For the cysts which are greater than or equal to 7 centimeter, laparoscopic surgery is advised. If the age of females is less than 40 years and she is concerned for her fertility, so ovarian cystectomy can be performed. But if not concerned, then oophorectomy should be done, because in case of cystectomy, there could be a part of cyst that is left behind, and there is high chance of recurrence. Okay, now coming towards complex cysts, they include solid multilocular or bilateral cyst. If non-functional, then RMI should be done. RMI more than equal to 200, CT scan abdomen and pelvis, and the patient should be referred to gynecological oncologist. If RMI is less than or equal to 200, then laparoscopic surgery is advised. Surgery has to be done in case of complex cyst. But if they are corpus luteal or hemorrhagic cysts, then the patient should be kept on conservative management, because I have told in previous slides that both of these cysts can be appear complex. So conservative management should be done, which includes early ultrasound scan, and then patient is discharged if the cyst is resolved. So this is all with my today's lecture, and I hope that this would be beneficial for the postgraduates to understand this very important topic.